All right, welcome to December 2025 of BlockHeads. This is a group for emergency physicians learning and discussing new innovations in regional analgesia as we try to give the best possible care to our patients. Today, I got Bob Stenberg here, who will be discussing several new types of blocks that we will be excited to hear about and have been talked about from our previous sessions multiple times. So, without further ado, I'm going to hand it over to Bob.
Howdy. Thanks for jumping on. Excited to talk to you all about this. So I want to talk about, some different shoulder blocks that I think are really interesting. So I kind of want to talk about them and also kind of hear what anyone else's opinion is on it, because I think it's a really cool group and want to hear what everyone else has to say and think too. So let's go ahead and jump right in. This is our squad here, so it's just kind of a fun shot. And then on the top right, those are two of those are incoming fellows. So cheers to that. So that's our squad. And kind of getting right into the meat. So I think one of the really tricky questions that we always think about is, we have someone that, is older, they're a little bit more concerned about taking out their phrenic nerve. And it's how are you going to manage these, proximal humerus issues, fractures, and also dislocations? And I mean, there's like a million different ways to skin that cat, and they all have little different nuances. And I think it's really kind of interesting to kind of really hone in on what is going to be the best for our EM bubble. And this is just it's a QR code to one of the articles that a bunch of people in this group kind of made, looking at different spots of the brachial plexus that you can block with kind of variations in the phrenic nerve, kind of, interscalene being the highest risk, and then coming further away, you have low risk for phrenic nerve involvement, but there's still phrenic nerve involvement. And also for a lot of people, these are still scary blocks, right? People are freaked out sticking a needle in the neck. So I think it's also kind of interesting to kind of play that out. We are focusing on the shoulder, and one thing I really want to do is highlight how the shoulder is innervated. And the easiest way to break this up is there are three primary innervations of the shoulder. The inferior portion of the shoulder joint is all innervated by the axillary nerve. And then the superior aspect, it kind of splits up. So that superior posterior aspect is largely covered by the suprascapular nerve. And then the superior anterior portion is just this grab bag of different articular branches from multiple different nerves that has a lot of variation in cadaveric studies. So this is kind of those are the three big buckets that we're going to be kind of reflecting on as we move forward here. It's just a cadaveric picture that I'm going to put in there for your reference. So I'm going to go through a case here. You have someone 80, they're old, they're frail. This is a theoretical case, but they have COPD, they have pulmonary hypertension, they have, they're on home oxygen, they foosh, they dislocated. Are you going to take out this person's phrenic nerve? And, how are you going to approach that? And kind of one of the initial, things is like you probably don't want to take out the person's phrenic nerve. So what are alternatives? And we're going to start off by kind of going through the shoulder PeNG, which was kind of, something that we started doing a little bit ago, and we've had a lot of fun with it. So this is a shoulder PeNG. It's now kind of called more like the interfascial plane block, which we're going to kind of discuss more in detail. But it is very simple. It is very easy. There's not a lot of scary things to poke in that area. What you're really doing is you're coming on that way anterior medial aspect of the shoulder, where you can identify uh, the kind of like subscapularis tendon, and then you are basically dumping medicine in between deltoid and subscap, and that's really all you have to do. And this is kind of a figure showing that, which is made by Brian Mikowski. So the original literature was all kind of coming craniocaudal, which we've kind of stopped doing. We just kind of get to the fascial plane. So here's kind of another image showing how to approach this. So, and I feel like the main blooper reel people get with this is they don't come medial enough on this. And the other tricky thing is, whenever anesthesia does this, they're doing it for a rotator cuff surgery or arthroscopic procedure. They're able to fully, externally rotate the arm and abduct the arm to really expose that subscap. But a lot of these people, they are, their arm is broken or they're dislocated, so their range of motion is pretty poor. So that does make one challenge about this. And, really kind of the big thing is just tucking that bugger real medial to see that subscap and get to there. But it's a really easy block, and people feel, the more that you're just aiming at a huge bone and there's no big vessel and no scary nerve to poke, I think people feel generally better about this. And we've had a pretty decent uptake in people in our group to be able to do these without really being too concerned.
Hey, Bob, this is Arun. I think you are going to get to the fact that if you can't externally rotate, is that correct? Because that's a
Right.
problem I've had with this block. Okay, good.
Right. Yeah. So that was kind of things. Yeah, anesthesia is able to kind of abduct it and externally rotate the arm, but you really can't do that. So we've still been able to pull them off for dislocations, just really cranking medial in that area. So I mean, we've been able to get a couple of these done. Here's just another image showing how to do that there. This is just going to be a series of, so just kind of an interesting case. So I was in triage, had someone that had a gnarly shoulder deformity and was on thinners, did, did a quick ultrasound, no dislocation. And then as I was going through, you can see, oh, the humerus stops. And so there's a proximal humerus fracture. And here is the X-ray. So we went and did kind of a little bonus hematoma block, but then we came and did a shoulder PeNG. So I mean, this person still had pretty limited range of motion, but we are still kind of able to get in between subscap and deltoid there. And this was at a freestanding. We had someone that had a shoulder dislocation and had a known subscap tear, which created this really cool like anatomic reference to kind of show that because there's already a bunch of fluid in between subscap and deltoid. So then all we had to do was come in between there. There's a little air just for funsies, nothing like some blooper reels. And then you could kind of see that anesthetic kind of really float into that potential space. And we were able to get away with block or just doing a shoulder PeNG with some Versa and able to get a reduction in with this. And then this kind of cues a little bit of a change on the anesthesia side of the literature where, it was, kind of like everyone's like, oh, this is the PeNG of the shoulder. And then when they started doing some cadaveric, evaluations of this, I kind of realized that this is kind of like it was already kind of done and it was kind of more of this like anterior approach of the like axillary nerve. And what they found is that they weren't when they injected into that space in between subscap and deltoid, they weren't actually getting the fluid to track along like the, capsule of the joint. But they're getting good axillary spread and good muscularitarian spread. And then, when I've done these, I've had some people that have had pretty good pain relief from a humerus fracture, but it was never like this amazing pain relief when I was doing a shoulder dislocation reduction. And the other thing too is because you're not having any motor blockade with this block, you're also still fighting a lot of muscle spasm. So a lot of times when I was doing it for a shoulder, I was still giving some Versed for that. So that's kind of, that kind of evolved this new concept. And this is just kind of showing, that this is just kind of like more or less how they're doing axillary nerve blocks and you weren't getting any glenohumeral spread. So this kind of cues in the SHAC blocks. Every time I see this, I just think Shaquille, which is kind
Hey,
of fun.
hey,
So
Bob, can I ask some questions before you go? Can you go back a couple slides?
absolutely.
Yeah, so just I've always thought the PeNG block was an intracapsular block for the hip. I've always felt it was not the classic teaching that you're getting all the innervating branches that go into the hip. I've always felt this is just an intra-articular block. You're just giving fluid in the capsule underneath the joint. And it just from your other view, go back to one. There's one other picture you had. It seems like you're doing the same thing here. Go back a couple slides. It seems like you're doing the same thing here. Yeah. So it's here, right? You're at the subscapularis, which you can see this is torn. And the one before it, you kind of don't know where you are, and you're just kind of going medial, which I think is fine, right? I think you're, yeah, exactly. So this is how I'd go into the shoulder joint if I wanted to give steroids, and not perfectly, but I think that what you're doing is you're just getting into that space. And I don't know if the answer, I don't know if I'm making this up, but you understand my point, correct?
Yeah. And the other really interesting thing too is, I mean, when you start looking at like subacromial joint injections, I mean, it's also basically just dumping, in that
Yeah.
spot underneath like deltoid and in between deltoid and suprascapular. So I mean, it does seem like there's a lot of overlap with that.
So what I mean by this is, so if you have a shoulder dislocation in an 80-year-old lady, you could argue with me, and I think this would be a really cool study. Should you just do an intra-articular injection versus doing a nerve block, which we've kind of moved to anyway? But I think this is just a more elegant way of doing an intra-articular injection, because what you're doing is as you pull out, you're also probably getting fascial planes and you're innervating this kind of big area. You're not just going into the joint, dumping it in. You're injecting the joint, and then as you come out, you're pushing probably anesthetic as well, and that's giving this infiltrative area to all the innervative sensory branches that go into the joint, and you're keeping it in a localized area. And hopefully that makes sense to you guys.
Nice. Thank you.
Okay, just want to make sure I'm on the same page as you guys.
But this kind of inspired this whole concept of a SHAC block. So anesthesia, I started realizing, well, what if we just do kind of what we're doing with interfascial and then we add going through the subscap? And they found that, there's a couple papers here, which I'm not going to dive into, but they kind of found that, that SHAC block had some kind of additive benefit. So this is kind of this is the first one that we did. It was a kind of a, pretty bad proximal humerus fracture. So we did a shoulder PeNG. We lifted, deltoid off subscap. And then what we did on the right side there, I'm gonna kind of do this one more time. But on the right side, now you can see we actually come deep to subscap, and then you inject the deep to subscap. I think some people kind of get freaked out by the concept of, burying a needle through subscap tendon, but we haven't had too many issues with this. So this person had really good pain relief after that. So another one here, we had a frail elderly, bad osteoporosis, had dislocation, needle coming down here, needle getting into your interfascial plane, shoulder pain type situation. And this was not very pretty either, but we still were able to get underneath subscap. And this person also had some really good improvement there. And this is just kind of showing, our pre and post on the dislocation. And, this is just kind of showing the patient had functionally no pain during the shoulder reduction. And maybe it was just kind of a really tough old grinding, but she actually had some really good pain control from the SHAC block with the reduction. It's just one more here of doing interfascial and then coming underneath subscap. And that person was pain-free after that check as well. This was something that came out this year looking at SHAC versus interscaling. And this one was saying, oh, well, they had some decent pain control, but still not as good as interscaling. And that just kind of they were kind of pushing the fact that, concerned that even though the SHAC seems better, you're still not catching all that subscapular nerve. So just real quick on the subscap, this is where you would come for the subscap nerve. So you kind of, which is also really easy because you're just coming down needle to bone and trying to get underneath that suprascapular muscle belly and underneath that fascial plane and dump along that fascial plane. Usually doing like 8 to 10 mLs on this. This is just actually our fellow did 2 of these this year. So just kind of showing one here and then another one there. Not fantastic spread. And I think you're usually kind of looking more for that notch when you did this, but both of these were oral successful. So I think one kind of big question as we kind of look forward to these is there's a lot of kind of variations with these different blocks that you can do. We, anecdotally, I've kind of found that, at least from like a case series standpoint, that doing the SHAC block did seem to be a little bit more reliable in terms of pain control and had a little bit better pain control. And I also kind of felt like when I've done them for reductions, comparing a shoulder PeNG versus a SHAC, I felt like at least the few that I've done comparatively, I felt like the SHAC had overall some better pain control. I think it would be, like kind of what was Arun was saying. I think there's a lot of interesting things. Should, kind of comparing what is the optimal, approach for doing these. Should we just be doing, intra-articular injections to reduce these, or are any of these other versions actually more helpful for these different procedures and kind of for hip, or excuse me, shoulder issues? So, I mean, I think there's a lot of different ways you could, skin this and approach it. And, I maybe if you did a SHAC and a suprascapular block, maybe that would have some more reliable coverage and maybe catching that posterior superior aspect better. But it also seems like a good bit of work. And I think the concept of, having to, you know, go in 2 different locations and do 3 different injections may be a little bit much for really what we're targeting with this, kind of that, that concept of regional analgesia like everyone talks about. So I don't really know if, going to the extreme of doing a SHAC and a suprascapular block is really necessary, but, I think some people would consider doing that. And I think this is a really cool, ripe area for research to kind of compare some of these different pieces in the setting of emergency medicine. This is just a summary, which I'm going to skip. And this is just something else that I wanted to throw out there. Brian Mikowski made a bunch of really kind of nice one-pagers. So if anyone wanted to click that, that's a pretty cool resource. And then I just kind of want to open this to discussion, kind of see what other people's thoughts were, what everyone's thoughts about, which one should we be doing, and is there even a combination we should be considering on this?
Hey, this is Fred Milgram in Denver. This is a great talk. Thanks for going through all this. I haven't dabbled with this nearly as much as you have, but a couple things that I've come across lately in trying to read about Phrenic-Sparing shoulder blocks. I thought, and it's been a while since I've reviewed this literature, so please correct me if I'm wrong, that the suprascapular is the majority of the shoulder innervation. So we started talking about this last year with our fellows. And I haven't done it yet for a dislocation reduction, but my fellow last year actually did like 2 or 3 suprascapular in isolation for people with chronic shoulder pain, and they had an incredible relief. And actually, functionally, it looks very much like a traditional PeNG block where you're finding that little divot and just depositing the anesthetic, and you're not going anywhere near a tendon or anything. So just from my experience and having done one of them with him as well, I think the suprascap is like a pretty elegant block. I don't know if I'd yet try it in isolation for a dislocation. But the other thing I came across like literally a week ago, and it sort of was uh, in one of the images you gave earlier, was the concept of the superior trunk block, which is also a Phrenic-Sparing shoulder block. I don't know if you were going to talk about that, but I talked about that with a colleague the other day, and actually Dan Zacola, who did a lecture with us a couple months ago. I texted him this block, and he did it yesterday, and he said he had an incredible shoulder reduction with it, which is just effectively a brachial plexus block right in between the interscalene and the supraclav, right before the suprascapular nerve takes off, which I'm excited to also try.
Yeah, Fred, I can talk about the superior trunk block. Yeah. So the problem with that block is I've done it now a bunch of times, and I think Joe has some more experience in the suprascapular. We've talked about this with the axillary block in conjunction after talking about Gadsden stuff. He has a good video on this. The problem that I have is the the superior trunk block. I mean, it's like a centimeter lower. If you do this, it's like a centimeter and a half lower. And I can't believe that the data there'll be so much difference in a centimeter and a half of real estate. And I think I know what the data says, but I just don't believe it. And I'm not trying to be a jerk about that. I think it's what I like about this block, the one that Bob talked about, is it stays completely away from the shoulder. And essentially, you're doing an intra-articular block like I talked about. And as you come out, you're going to inject. And as you come out, you're going to get into the space where the axillary nerve is. So I really do like that. And I think Joe can kind of his experience with suprascapular and axillary.
Varun, I think the superior trunk blocks, I've done this quite a few times. I think it's just the reason why it has such a lower rate of phrenic nerve is just it's such an easier plane to get into rather than the interscalene plane. Because if you miss it all and start injecting outside, the likelihood of it just being absorbed to the phrenic nerve is just that much easier. I that's just a gut feeling. I don't know.
Yeah, no. If you talk, the person who talks about this a lot is Ki Jin, and he's a smart dude, and I've talked to him specifically about this, and the data supports it. But the problem is that data is in the hands of really, really picky anesthesiologists with very small numbers. I think if you really want to not worry about the phrenic, which I don't worry about very often, I think the SHAC block's a reasonable block, or the axillary with the suprascapular. I think you just have to assume that anything above the clavicle is going to give you some potential, because the superior trunk is higher than the supraclavicular brachial plexus, right?
Yeah.
And there are numerous cases of supraclavicular brachial plexus causing phrenic nerve paralysis, and I can't believe that going above that doesn't give it to you, but below it does. It doesn't make sense to me. And just from a anatomical point of view, and maybe there's a ligament that I'm missing, but so I think that I like the fact that you're just doing it, that Bob's doing an intra-articular block, and as he pulls back through the subscapularis tendon, excuse me, he's just injecting a bunch of anesthetic and kind of bathing the area, which is a simple way of getting around this once in a blue moon conundrum, or not once in a blue moon, maybe more often for other people. But I think that's the key. I think the 2 injection, which Joe likes, and he could talk about it, I think is a little bit more work for people that are novice.
I agree with you. I do like this technique. I haven't done it myself, but I've done the superior trunk, but I haven't done this one that Bob's.
Yeah, I've done probably a dozen or so of suprascap plus axillaries, and I think that really gets you, like, it essentially gets you your interscalene without any even remote risk of phrenic nerve palsy. It is a second injection, but I think the anatomy for both is pretty easy. You've got bony backstops on both. Like I think that's a great block for anybody that you're actually worried about their phrenic nerve. I mean, I still do interscalenes for the majority of shoulders, but you know, if there's somebody I'm worried about, I have very low threshold to switch over.
And just 15 years of this, I've yet to see one go down bad, and maybe we're just selective and don't do it in older patients, but we've done tons of supraclavicular and interscalenes, both with incidents of phrenic nerve paralysis, and we even have seen phrenic nerve paralysis, but it hasn't affected the patient clinically. So I'm not saying that we should not think about this, but I think it's a very rare occurrence.
And yeah, so Azra has something about doing that combo axillary and with the suprascapular. And, other things that I've read have said that, the suprascapular nerve has up to like 70% of the innervation for that shoulder joint. So pretty, kind of like what y'all were saying, a decent one shot wonder kind of thing. But I think one other thing is I still think, I think Joe was kind of mentioning kind of having that like comfortable anatomy. And I think one thing I do like about this is, they're nowhere near the neck, they're nowhere near the subclavian artery. So I think for a lot of people, especially as you kind of look at implementing this to kind of more in the community setting, I think, when I talk about this at ASAP and stuff too, I think people really feel pretty comfortable with the concept of you're nowhere near the brachial plexus, you're nowhere near, the lung, you're nowhere near the phrenic nerve. So I feel like when you kind of look at that implementation piece, I think this seems a lot more digestible for as you kind of spread it out to a huge group.
Yeah, I like this, Bob. And I like the SHAC more than the PeNG because then you can just kind of come in, hit the bone, inject, and pull back.
Yeah, I think all of these are great. Just to be clear, and I agree. Like I've never had an issue with the phrenic necessarily, and absolutely you could probably hit the phrenic regardless of which of those brachial plexus blocks you do. One thing that I'm excited to try the superior trunk regardless because I think my feeling is that people are probably accidentally going superior trunk anyways because they're not finding interscalene anatomy. And even
100%.
the idea of saying like I'm actually not near first rib or pleura and I'm not near phrenic nerve, but I know that there's some brachial plexus roots here, and if I inject, I'm probably going to get a pretty effective block. That being said, I'm also excited to try the two injection technique with suprascap and SHAC.
And Fred, the only worry about the super scap is the fact that you have to really delineate the leaving of the suprascapular nerve, superior trunk, excuse me. And when I've done it, and I've probably done a few of these, I haven't done millions, but enough that I know that there's less of landmarks and there's more of like kind of you have to pop through fascial planes, and it's a little bit more of a kind of a fun block for me, but less of a fun block for my intern, if that makes any sense. For
Yeah,
me
totally.
watching the intern.
Hmm.
Great talk, Bob.
Thanks. Well, that's all I had. I can just put back up this resource page if anyone wants to snag that again. But yeah, that's kind of all I want to talk about. So thanks for the input. I really appreciate hearing everyone's thoughts.
I think that was pretty great. Just so everyone knows what we got coming up next, we'll be talking with Dr. Di Pietro from Italy on a recent randomized control trial for PeNG versus fascial compartment block for hip fractures. So that'll be on January 30th. Thank you again to Bob for his discussion today. Thank you for everyone who came in attendance. If anyone has any additional questions or talks that they want to have fielded by our experts, or if you yourself want to give a talk, feel free to reach out to me. It is in your email. You guys have a great rest of your day and happy holidays, everybody.
Happy
Thanks,
holidays
gang.
all.
Thanks. Awesome.